This topic is pleural effusion. When we talk about pleural effusion, we are talking about a collection of excess fluid within the pleural space. Now, the pleural space lies between the visceral pleura, which is a serous membrane that lies directly against the lung tissue, and the parietal pleura, which is a serous membrane that is attached to the chest wall. As this fluid accumulates within the pleural space, this is going to lead to a compression of the lung tissue and lead to a decrease in gas exchange within the lung. It's important to note that pleural effusion is not a disease itself, but the result of a disease process. And some of the disease processes that can lead to the development of pleural effusion include heart failure, nephrotic syndrome, pneumonia, and malignancy. This image may seem overwhelming, but we want to look at this slide to better understand how fluid can accumulate within the pleural space and lead to pleural effusion. Let's first start by looking at the section of the image on the far left, showing how fluid and pressure are normally maintained within the capillaries, pleural space, and lymphatic system. Hydrostatic pressure refers to the pressure exerted by the fluid within the capillary, while oncotic pressure refers to the pressure exerted by proteins within the blood that help to retain fluid within the blood vessels. Normally, the hydrostatic and oncotic pressures are balanced, which will only lead to a mild leakage of fluid from the capillary. This fluid will help lubricate the pleural space and eventually drain into the lymphatic system. Changes to hydrostatic or oncotic pressure can lead to an increase in the amount of fluid that leaks through the capillary wall and lead to the development of pleural effusion. The second section of this image shows us how pleural effusion can develop when we have an increase in hydrostatic pressure, such as when we have fluid retention from heart failure. Excess fluid within the capillaries will increase pressure against the blood vessel wall and overwhelm normal oncotic pressure, leading to an increase in fluid within the pleural space. The third section of this image shows us how pleural effusion can develop when we have a decrease in oncotic pressure. A decrease in oncotic pressure will occur secondary to a loss in circulating proteins found within the blood, such as from nephrotic syndrome or liver disease. Decreased protein content within the blood will decrease fluid retention by the capillary, leading to a net increase in fluid accumulation within the pleural space. The fourth and fifth sections of this image demonstrate the development of pleural effusion from increased capillary permeability and lymphatic obstruction. Increased capillary permeability occurs due to inflammation or infection, such as when we have pneumonia, while obstruction of lymphatic fluid drainage can occur from malignancy and an increase in the presence of cells within the pleural space. The cells block lymphatic drainage and fluid accumulates. It is important to note that we are talking about these processes in relation to pleural effusion specifically. However, changes in hydrostatic pressure, oncotic pressure, capillary permeability, and lymphatic drainage can affect other areas of the body, leading to manifestations such as peripheral edema and abdominal ascites. Clinical features of pleural effusion are going to be related to that buildup of fluid within the pleural space and compression of the lung tissue. We would expect to see the development of dyspnea, and the client may also have a cough. If the pleura itself becomes inflamed, the client may develop sharp chest pain on that side that has that pleural effusion. Essentially, this pain will be localized and will not radiate, and it will increase during inspiration as that inflamed pleural tissue begins to expand. Most likely, we're going to notice decreased breath sounds as well as decreased movement on the side of the body with the affected lung. If we percuss over the lung itself, we're going to hear dullness as opposed to a resonant sound that we would normally expect. Tachycardia may be present to some degree due to decreased oxygenation, as well as if that pain is present from that inflammation. A pleural effusion is most commonly diagnosed through the use of a chest x-ray. And if we don't know the cause of the pleural effusion, a diagnostic thoracentesis may be necessary to test the fluid for the presence of malignant cells or infectious microorganisms. A complication of pleural effusion is empyema. Empyema refers to a collection of pus. This can occur from a complicated case of pneumonia or can occur at a later point in time once a pleural effusion has been present. Bacteria love a wet, moist environment. So the longer that we have that pleural effusion, the more likely we are to develop that empyema or pus collection due to those microorganisms. Due to the presence of these infectious microorganisms, we're going to see clinical manifestations associated with that, such as the development of fever and chills, a toxic appearance, meaning the client appears fatigued. The client may have some weight loss due to increased metabolic needs within the body, as well as a decreased appetite. And we would expect to see the presence of leukocytosis. Nursing interventions for pleural effusion are going to focus on decreasing fluid accumulation within the pleural space, increasing lung expansion and gas exchange, and treating any of the underlying causes that have led to the development of that pleural effusion. To increase lung expansion, we want to elevate the head of the bed, and if a pleural effusion is quite large in size, we can anticipate therapeutic pleural drainage, often through the use of a thoracentesis, which is depicted on the image on this slide. With a thoracentesis, a needle is inserted into the pleural space and attached to a drainage bag to allow for fluid to drain from the pleural cavity. It's important to obtain a chest x-ray after the procedure, not only to make sure that the procedure has been successful, but also to make sure that the lung has not been punctured by the thoracentesis needle itself. Throughout the treatment process, it's important that we monitor breath sounds and encourage coughing and deep breathing exercises to help promote lung expansion and reduce any further atelectasis of the lung.